Ladies and gentlemen, amigas, amigos, gracias de participar con nosotros a este fantástico evento de las Jornadas Científicas en Salud Femenina. Eso es un evento que...
Thank you for participating in this meeting. Please speak in English because you are in the English channel.
Oh, I'm sorry. Okay. Okay, ladies and gentlemen, thank you very much for being with us. It's this event of the Jornadas Científicas en la Salud Femenina, which was sponsored by Besens Mexico. I would like to thank you very much, Besens Mexico, for the effort and the support in the initiative of the International Academy of Human Reproduction. And in particular, because this event will be dedicated to a very interesting topic, which is progesterone in obstetrics. And as you know, obstetrics endocrinology is a very important chapter of our discipline. And inside to that one, there are a series of research in these last years who have provided the fundamental role of progesterone for a good pregnancy and for the maintenance of pregnancy and also for the establishment of the pregnancy and for pregnancy termination too. And it's my pleasure to invite the first of our speakers. We will have two speakers. One is Paul Piet and the other Hoda Harb. And Paul Piet, he will make a speech on pharmacodynamics and safety of progestogen, progesterone, and progestin. Paul Piet he was the scientific director of Besens. He is now one of the important investigators in this area of obstetric care, and he have a huge series of publications on the fundamental role of progesterone for women health in pregnancy, but also out of pregnancy, for menopause treatment, and for many other chapters. He is a member of the Praise School in Florence. And Paul, you have now the microphone to speak about the pharmacodynamics and safety of progestogen, progesterone, and progestin in obstetrics. I thank you very much.
So thank you, Andrea, for this nice introduction, and I want to thank the Human Reproduction Academy to invite me to this scientific session and this virtual, unfortunately, virtual webinar. My topic of today will focus on the pharmacodynamics and safety of progestogens, progesterone, and progestins in obstetric, balancing the effectiveness and the safety. So that's my financial disclosure. I'm a consultant, as you know, at Besens Healthcare Company. So first of all, I want to show you how important is progesterone during the whole pregnancy, not only from conception. You know that you need regular cycle to be pregnant, but progesterone plays a crucial role for implantation during the first trimester, preventing early or even late miscarriage, and that will be addressed by the next speaker. We have also some good data about the effectiveness of progesterone in the prevention of preterm birth, and there are ongoing research on preeclampsia. So you can see that during the whole duration of pregnancy, progesterone is a key hormone to maintain pregnancy. And I was addressing in a recent publication in the YBEO Journal 2020 the pharmacodynamics and safety of the progesterone molecule, which is the nature choice, at least for pregnancy maintenance. But what I want also to share with you is the safety profile of progesterone, which is crucial because we are speaking about an intervention during pregnancy, and also the importance of the route of administration. So progesterone is a very important molecule because, as you may know, this molecule was involved with 4 Nobel Prizes, which is very unique in the terms of medicinal product. And the discovery of progesterone was by Adolf Butenandt in 1939. And you know, there is a long story about the effectiveness of natural progesterone. In fact, it's a never-ending story, as it was mentioned in the climacteric review about 2 years ago. So my first key message from my presentation is to show that different progestogens may differ in their hormonal activity depending on their structure. And as you can see, even small changes in the molecule can induce very different pharmacological effect. Progesterone, for example, is a flat molecule comparing to dihydrogesterone, let's say a very close molecule of progesterone. But in dihydrogesterone, which is a truncated molecule, you have a double liaison here and a different structural formulation. And those small structural changes in the configuration of the parent steroid molecule, progesterone, will induce, as you may see, we'll see considerable differences in the activity of the derivatives. And just to look at the biological activity of progesterone and the synthetic progestin, as you can see, the activity and the pharmacodynamic is not depending only from the binding to the receptors, but also the binding affinity. So you can see that some molecule can bind the receptor, but being not efficacious because the binding affinity with the receptor is not optimal. And looking at different progestogens, you can see that the binding affinity and the effect on the receptors depends the molecule. And progesterone, for example, has a slight anti-androgenic effect, an anti-mineralocorticoid effect, a diuretic effect. And what is unique in the molecule of progesterone, it binds the GABA receptor, which is not the case of very other close molecules, such as dihydrogesterone, for example. So different molecules can lead to different pharmacodynamic effects. So when I summarize all the pharmacodynamics characteristic of micronized progesterone versus progesterone for pregnancy maintenance more specifically, what I want to share with you is that not only the mother molecule progesterone is important, but also the metabolites of progesterone who will activate several progesterone receptors, progesterone A, for example, progesterone B, which has an antagonistic effect comparing to the progesterone A receptor, and also some very quick effects that doesn't need the classical genomic pathway, meaning that progesterone can bind membrane receptors with a very quick effect in a few minutes. But for the early pregnancy maintenance, and certainly for implantation, we know that progesterone is crucial to transform the endometrium and to have a secretory transformation, decidualization, vasodilatation, decreasing the apoptosis, and promoting extravenous trophoblast invasion in the maternal decidua and remodeling the local vasculature. That's the key pharmacodynamic effects to favor implantation just before the initiation of pregnancy. But during the few weeks after implantation, progesterone plays an important role in modulating the maternal immune response because, as you may know, the fetus is half coming from the father and can be considered as a semi-allograft. And to avoid any rejection from this semi-allograft by the mother, it's important to modulate the maternal immune response, and that's the key role of progesterone in the early pregnancy maintenance. We also know that progesterone, for example, but not dihydrogesterone, this very close molecule, improve the uteroplacental circulation, which improve the blood flow in between the mother, the fetus, through the placenta. Also, progesterone suppresses the fetal immunoplacental inflammatory response because inflammation is also a key factor who can be responsible for threatened miscarriage, as it will be addressed by the next speaker, or even for premature delivery. And so also progesterone participates to maintain the uterine quiescence during the whole pregnancy, to maintain cervix integrity. And to keep it simple, a delivery process is not more, not lesser than an inflammatory process at the cervix level, and progesterone plays a key role to block the inflammatory prostaglandin production, which will induce corticotrophin-relieving hormone release, leading to a premature birth. Progesterone also blocks cervix ripening, and that's probably a very recent discovery, that we know now that progesterone is also important to reduce uterine contractility, not only at the end of pregnancy, but in the early implantation stage, when the trophoblast will invade the uterus. So this anti-contraction effect is very important also in the pregnancy maintenance. As you may see in this cartoon by the group of Arena and Hernandez, published in 2019 in Journal of Immunology, you can see that progesterone blocks the activation of effector T cells, which are involved in the pathological inflammation into the intra-amniotic cavity. And this inflammation process is through the activation of macrophage and the activation of B cells and interferon, which are responsible for the initiation of the labor. And if this occurs prematurely, you have a high risk for preterm birth. So progesterone is not crucial not only in the implantation process and in the early pregnancy maintenance, but it plays a very important role in the late pregnancy to prevent a preterm birth. When we summarize the different pharmacodynamic characteristics between progesterone, the mother molecule, and synthetic progestin, we can summarize 4 important points regarding the pregnancy maintenance. First of all, progesterone has a tranquilizing effect, because the major metabolite of progesterone, which is allopregnanolone, fixes the GABA receptor, and it was nicely shown firstly by Laureen Dennerstein in the late 80s, published in the British Medical Journal, how progesterone can work for binding the GABA receptor and having a tranquilizing effect, for example, in premenstrual syndrome indication. Secondly, you know that during the whole pregnancy, there is a huge increase in estradiol. So many experts thought that, in fact, progesterone is increasing during pregnancy that much compared to estradiol. But in fact, it's exactly the opposite. It's really estradiol which is increasing dramatically during the whole pregnancy. And it's very important to have an hormone to counteract this hyperestrogenic pattern during the pregnancy. And that's exactly the role of progesterone, having a diuretic effect, an anti-estrogenic effect, because only progesterone binds the aldosterone receptor, being a potent anti-mineralocorticoid hormone. I mentioned that progesterone has tocolytic effect, which is important for the implantation and for the late pregnancy maintenance. And last but not least, progesterone exerts very important neuroprotective effect, and you will see that it's very important in the morbid mortality in the neonates, and certainly when you have preterm birth. Why is this hormone more and more considered as a neurohormone? And I think that our chairman today, Andrea, knows this story very well. He was the first emphasizing the role of progesterone and the production of progesterone at the brain level. And what's interesting in this cartoon is to see that the brain has the whole equipment, like in the ovaries, to produce progesterone from cholesterol, and that's exactly the same pathway as in the ovaries. But on the contrary of the ovaries, when progesterone will be metabolized in allopregnanolone binding the GABA receptor into the brain, this reaction is reversible. So into the brain, progesterone can be produced from allopregnanolone back from the initial pathway. So that there is a real regulation at the brain level, which probably plays also a crucial role in the pregnancy and certainly for the neuro effect at the fetal level. So we know since a while that progesterone has some effect on the uterine contractility, but we know now better how works progesterone as a neuroprotective hormone at the fetal brain through the allopregnanolone, which modulate the inhibition of the GABAergic actions. It controls the balance of the fetal behavior, and it protects the fetal brain from hypoxia and ischemia, which is a real problem when there is a premature labor. I was also showing how important is the route of administration, and as you can see, depending the route of administration, progesterone blood level will be dramatically different. If you administer the same dose, 300 milligrams a day progesterone by oral or by vaginal route of administration, you can increase progesterone blood level at the steady state, but surprisingly, you can reach higher progesterone blood level when you administer the same dose by the vaginal route of administration comparing to the oral. And based on those PK/PD study, we determine the optimal dose for luteal phase support, for example, in IVF cycles, where 600 milligrams a day lead to a progesterone blood level which is above the magic cutoff level of 10 nanogram per ml. This cutoff level, which was defined by Jordan in the late 90s as the cutoff level, the minimum progesterone level you need to avoid any luteal phase deficiency. Very interestingly also, if you administer progesterone by the intramuscular route of administration, you will reach supraphysiological level of progesterone, 5 to 7-fold more progesterone at the blood level comparing to the vaginal route of administration and to compare with normal luteal phase in a young woman. And that was nicely demonstrated by the group of Miles in Fertility Sterility 1994, where you can see that comparing intramuscular progesterone with vaginal progesterone, in this study was 800 milligrams a day vaginal progesterone, despite very low blood level, above this magic cutoff level of 10 nanogram per ml, you can see that with the vaginal progesterone route of administration, you reach high level of progesterone into the endometrial tissue, where the progesterone is supposed to be active, and on the contrary, with intramuscular progesterone, the levels, the blood levels are 5 to 7-fold higher comparing to natural phase, luteal phase, but you have very disappointing progesterone level at the tissue level into the endometrium, and we understand now exactly how it works, what we call the first uterine passage, showing that there is a direct diffusion of progesterone from the vagina into the uterus by a counter-current transfer, because there is a passage from the vein to the ovarian artery, increasing the progesterone level into the uterus, very importantly, where the implantation will occur. So let's start also with the guidelines and the recommendation. Is there any difference between progesterone and progestin? And you know, for example, that in IVF, You have the recommendation for the American Society of Reproductive Medicine, published in Fertility Sterility 2012. But we are in Europe, and in Europe we have the ESHRE recommendation with a nice recent publication summarizing all the recommendations of the ESHRE, and where progesterone is recommended as a first choice, vaginal progesterone, for luteal phase support since 2019, confirmed in the very recent guidelines 2020. But when you look at the recommendation for other progestogens, like dydrogesterone, for example, there is only a conditional recommendation because the expert group was showing that dydrogesterone, which is an orally active progesterone close from progesterone, has a difference in structure, and there are some concerns regarding the safety for the offspring. So you can see small differences in the progesterone molecule can induce a different safety profile. And unfortunately, the LOTUS-1 and the LOTUS study comparing natural progesterone to oral dydrogesterone as luteal phase support in IVF cycle, those two studies were insufficient to make a firm statement on the rate of congenital anomalies, and there was a lack because there was a lack of long-term offspring health studies. So different molecules, different safety profile. When we go from general awareness to practical experience, what did we learn from clinical trials? In fact, we have to balance, as I was mentioning in the title of my presentation, effectiveness and safety. And you will see that when you look at the Cochrane review, in fact, all progesterone are equal efficacious in increasing live birth rate, clinical pregnancy, or ongoing pregnancy rate. But what I want to emphasize on this slide from the Cochrane review, you have a huge placebo effect, which means that if you want to make non-inferiority studies comparing all those progestogens together for luteal phase support in IVF, you need to randomize more than 1,000 or even 2,000 patients to make a difference between the active group or the placebo effect. So we have to be very careful when we go for non-inferiority studies. And looking at the Cochrane review and all the available luteal phase support, you can see that comparing intramuscular versus vaginal route of administration, vaginal versus rectal, low dose progesterone versus high dose, and micronized progesterone versus synthetic progestogen, at the end of the day, there is insufficient evidence to recommend any one particular protocol. So we can raise the question, following question, why is vaginal progesterone still considered by most the first option? And so to answer the question, we can first go to the pharmacodynamic characteristic and comparing, for example, intramuscular injection, which are painful injection, comparing with vaginal progesterone, giving a minimal discomfort to the patient. Also, looking at the intramuscular route of administration, as I mentioned a few slides ago, there are supraphysiological blood level of progesterone. You need a nurse to administrate the progesterone, and you can induce a lot of adverse events, even eosinophilic pneumonia, were shown in some cases administrating progesterone by the intramuscular route of administration. Look at the vaginal route of administration, the progesterone blood levels are very constant and very optimal above this cutoff level of 10 nanogram per ml. You don't have any first liver pass effect, so it's a safe route of administration with the first uterine passage and no irritation or discharge depending the formulation. And again, we have to be careful when we compare different vaginal progesterone formulation. But Janusz Polski in the US published in Fertility Sterility a comparison between vaginal and intramuscular route of administration in terms of patient satisfaction, the convenience for administration, the easy to administrate, and the overall satisfaction of the patient, and the odds ratio was statistically significantly in favor of the vaginal route of administration. So the patient acceptance for this route of administration is optimal. In some cycles in IVF, we know now that to avoid any risk of ovarian hyperstimulation syndrome, we prefer to go for FET cycle. And then the question is, do we need to increase the progesterone dose? And in this study by the group of Thomas 2011, it was shown that in addition of the classical vaginal progesterone, we can suggest to add some oral progesterone to decrease the abortion rate and even more importantly to decrease the bleeding profile. So the key message from this publication is showing that in case of bleeding in the early pregnancy and more especially in IVF cycle, increasing the progesterone daily dose will decrease the bleeding profile, and that will be confirmed also by the next speaker addressing the results of the PRISM study. When we look at what our colleagues are doing around the world in IVF cycle, you can see that most of the centers around the world are using more and more vaginal progesterone only. It was 64% of the FET cycles, based on more than 250 cycles a year in 82 countries. And now we have about 80% of IVF centers using progesterone only as luteal phase support. And despite the two recent non-inferiority studies, the Lotus 1 and the Lotus study with oral digesterone, you can see that oral digesterone is only used in less than 5% of the cycles around the world, based on an update 2020 published by the group of Di Guardo. So vaginal route of administration remains the first option because we have a huge experience and we have more than 5,600 patients in randomized control trial showing how progesterone works, not only on the clinical pregnancy rate, but also the ongoing pregnancy rate in IVF cycles. So there's a very nice review by Elena Labarta in YBO Journal 2020 showing the optimal daily dose of vaginal progesterone capsules in IVF. It goes from 600 to 800 milligrams a day depending the study. And it was also nicely addressed by Elena Labarta that probably the optimal daily dose of progesterone is different in function of the procedure in the IVF cycles. We have to increase the daily dose of progesterone, for example, in artificial cycle, comparing to stimulated cycle or natural cycle in IVF procedures. Moving now for the prevention of preterm birth in the late pregnancy, probably the most documented meta-analysis was published very recently in the Lancet 2021, what is named the EPIC International Collaborative Meta-Analysis. It was an individual participant data analysis from randomized control trial. And in this meta-analysis, as you can see, the progesterone capsules were decreasing the rate of preterm birth significantly. So the conclusion and the key message from this Lancet publication are that vaginal progesterone reduces birth before 34 weeks of gestation in high-risk singleton pregnancy. The absolute risk reduction is greater for women with a short cervix, and the results for other birth and neonatal outcome were also consistent. Supplementary analysis of subpopulation with a short cervix were in line with the main result and support the previous observation of treatment benefits for women with a cervical length less than 25 millimeters, irrespective of the obstetric history. That's a very strong statement and conclusion coming from this very recent meta-analysis published in the Lancet in 2001. So what about safety? We have a huge experience now about the safety of micronized progesterone used during the whole pregnancy and more especially in the late pregnancy or in the early pregnancy based on the PREDICT study. It was a study in twins for prevention of preterm birth, the Fonseca trial by the Fetal Medicine Foundation in UK, the pregnant study in the US, the Optimum trial in the UK, and the PROMISE and the PRISM studies result addressed by the next speaker. So we have now about 9,000 patients in randomized placebo-controlled study showing the safety on the neonatal effects, the health infant, and showing that micronized progesterone capsules are cost-effective in pregnancy maintenance, not only in the early pregnancy in case of threatened miscarriage or recurrent miscarriage prevention, but also in the prevention of preterm births. Again, we cannot compare all progesterone together, and in this meta-analysis published in the expert review of clinical pharmacology recently 2020, they were looking at the safety of dydrogesterone, for example, and in this meta-analysis there was a consistent increase in the cardiovascular malformation in the neonates based on a fixed model or a random effect, showing that there are some safety concerns on congenital malformation, and more especially on congenital heart malformation when using dydrogesterone during pregnancy. So we have to be very careful. Also, case report control on a woman who has to go for a liver transplantation because of delayed fulminant hepatic failure. And so all concern where we have to be very careful when it goes about intervention during pregnancy. And this was in March 2020 in Human Reproduction, confirmation that we have to be very cautious when we administrate synthetic progestogen like dydrogesterone. And even in some countries in Europe, dydrogesterone is contraindicated for pregnancy maintenance, more especially in France. This product is not indicated in pregnancy. So again, there is huge difference between progesterone. If it was to monitor progesterone level, we know that administrating progesterone by the vaginal route of administration, you can monitor progesterone level, and this was recommended by Elena Labata in her publication beginning of this year, showing that you can optimize luteal phase support in IVF procedure, measuring progesterone and looking at the optimal progesterone blood level in the day of the embryo transfer, that you cannot measure with dydrogesterone because you need sophisticated laboratory assay to measure dydrogesterone in the early pregnancy, as it was mentioned by Balash in the 80s. You don't change the progesterone blood level administrating dydrogesterone, so no possibility to monitor the progesterone blood level with synthetic progestin. So in conclusion, we can say that progesterone, vaginal progesterone, remains the treatment of choice for pregnancy maintenance because you have a first uterine pass effect with a high local uterine concentration, and you target your progesterone action where progesterone is needed into the endometrium. You induce optimal endometrial late secretory transformation. You have an optimal bioavailability with very stable progesterone level comparing to intramuscular or subcutaneous route of administration with very short acting action. It's convenient and user-friendly, as it was published by Jan Opolski. It has been extensively used in fresh and frozen IVF cycle, and it's supported by a huge clinical evidence and high live birth rate, and very recently also nicely shown in the PRISM and the PROMISE trial for the prevention of threatened or recurrent miscarriage. And last but not least, avoiding the first liver pass effect, and there is absolutely no risk of any side effects or irritation at the gastrointestinal tract, which make the vaginal route of administration the more attractive route of administration for micronized progesterone for the indication in pregnancy. So I thank you for your attention and open for questions. Thank you.
We thank you. We thank you really for the beautiful presentation and for the level of the consistency of the data that you have provided in any aspect.